you guys? Okay. So for me, it's all about speed, repeatability, consistency, and legality. Because, I'm trying, my patients are coming to me so that they can get a better deal. Affordable dentures is everywhere, Aspen dentures, Aspen dentals everywhere. And they have in-house labs, so you have to be able to compete with them if you want to do this in private practice. So if you're paying $500 for a denture from your lab, you can't compete. So you've got to be able to pay $40, $185, and you got to be able to do it the day they walk in, because Aspen dental can. They'll make them a denture that day. So this allows you to have a lot of flexibility. Now, since this is the GMDIA, we do a lot of conventionals. And this is the idea of mixing. I'm going to show you this, which is new to this country. I'm going to pass that around. So what this is it's a pure titanium bar, and this is set up for Zimmer implants. Each one of these is a non-engaging abutment that you screw in to each of your implants per arch, so like this here. So if you wanted to do a screw retained removable, you could. Okay, I have another way to do it, but this one allows you to splint everything. If I can borrow that back, just so I can kind of show it to everybody. So these move around the bar, okay, and you do this chair side. So this is a newer thing. There's like 2 companies that have something similar to this. We used to weld these. The weld one is a machine from Dentsply, and you go, you basically bend the titanium, put it in there, and you weld each one. This allows you not to buy the machine or do that. So these slide on and off the titanium bar, and when you tighten this down, it actually locks it into place. So what you would do in the mouth is you take the bottom piece and you put that in the implant and you tighten that down. Then you bend the bar to fit each one of these, and you go back like that, and then you screw that down. And these are the screws that then this would get, basically the top piece gets picked up inside the denture, and the bottom piece stays inside the implant, and that's how you make a screw retained. This would be like an all-on-4 right here. This is also available from just getting a video. So there's 4. So this part stays in the tissue, and then this part goes into the denture. And then this is a titanium bar you bend chair side. Okay, I'm gonna hand it to Bruce now. And then this is what it looks in the package. So there's a straight bar, and then these are the individual components right here.
Do these slide around on the bar?
Mm-hmm.
Okay.
Yep. So you bend the bar. So the way you do the one piece at a time, you just keep sliding it in. You just work your way around the arch like that. Okay. But this is again a pre-made, so it's all about lowering your lab fee, saving the money, things like that. So if you like to do conventional cases, or if you're mixing like me, or even if you need to do a temp, I personally am trying to stay away from screw retain for longevity purposes, but that doesn't mean you too. And if you like doing them, this is a great way to go too. So I don't know if you want to see that. So if everybody's seen it that wants to see it, there you go. So that's another way. If you don't want to do it, I'm sure your local lab guy will come in and do it for you. So anyway, our patient got in a car accident this morning and totaled his vehicle. But of course, opposing that little tri-lower bar, he floured that implant just like that. And why did this happen? Well, I could say lots of reasons, but I'm going to blame everything like everybody else on COVID, because he did not get his Botox injections for COVID. So he came back after COVID and he's like, I don't know, kind of hurts a little bit here. And it was just some red swelling. I took the x-ray and I could see that it was floured. At that point,
Excuse me, he was taking Botox for his TMJ.
He's taking Botox to decrease his masseter force because of the bruxism, which did not go away due to his job. And so that keeps him from biting so hard that he fractures. If he can fracture teeth, he'll fracture implants. So he was, I have probably 20% of my patients are on Botox injections every 3 to 4 months just to keep their bite force in check. And you can see that in those photos too. If you look at how he was really squared out and how his jaw ovaled out afterwards.
Do you do the Botox?
I do. Yep. So if you guys want to talk about Botox later, I can show you the grid that I use for doing Botox. So yeah, he came back after COVID, and that implant was basically fractured. And so I went in and uncovered it, cleaned it out as much as I could, and then put this back on. You can see I just used the same abutment, and I couldn't even get it centered the way it was. But it was I grafted it a little bit and tried to improve the amount of bone loss that we had. So if I have this one here, that's a good question. So you can see I improved the amount of bone that I had around this. And I did that before I wanted to change out the implant. So today, if he shows up.
Did you graft in there, doctor?
I did. I grafted it.
Okay.
And I made sure that there was no force on it. So I basically made it, I used a flexible cement inside the prosthetic on that one, just to increase the amount of force. And then Rick, I promised you a zirconium abutment for a mini implant, and that is it right there, if you want to show that. So what I do with that zirconium abutment, just to change tacks for a second, it's registered on 4 sides, so it matches up with the 4 sides of the square on the mini implant. And then afterwards, I prep that. So if I have a case where it's really tall, or if I want to change the angle and do custom abutments on minis, I use the zirconium ones. I just seated a lower anterior 4-unit bridge, all 4 minis, all 4 where I had really long lower incisors. Sometimes you get those, and so I use those. I like that.
So you cement those onto the minis.
Yeah, you cement them onto the minis. In the mouth, you can use them actually, to actually transfer that to the lab if you want. But the lab will then prep them, or you'll prep them, and then they make the crowns right on top of those. Yep.
I recently did those laterals that you and I did together with those, and it came out really nice.
Oh, that's awesome. Yeah.
They only go on one way, so you can mess it up.
Right. Yeah, which is nice, isn't it?
You have a little
Alright, so
dish for this thing, a little container for
Right,
that.
if you look, this is the blue bite, and then you can see the square rim inside. So this was my rim, and if you look, it'll snap right into that little piece. So that's what the lab got.
Something I could take it home with, like a little sterilization pouch would be fine.
Well, it also makes sure that I get all of the vestibule as well. So if there's any kind of, if you give them too little instrument, you could be wrong. If you give them too much, they don't care. And it's, 50 cents. I'm frugal, but 50 cents of extra glue mousse to make sure the case works is great. So, I do about, I think it's been 2 dentures a week average for over 20 years. So I've tried every technique out there, everything out there. I'm keeping, experimenting as you can tell. And this has by far been my go. Yeah, this method here for just a regular conventional thing. And then what the lab does is they take that, they put it in an articulator, and then they make a registration jig. And that's a much harder material. And basically that's the 2-part putty that we all used in school. It's like a hard polyvinyl siloxane. And from that, basically the lab mounts the case permanently, because this is, we wrap that pretty carefully to send it out. And it's a little bit fragile. So, if you keep playing with it over and over, you'll break it. So they make that registration jig to mount the case, and then they send it back. So I send them an impression basically of the original denture, so they can match up everything that the patient had. And you can see this was a monoplane occlusion in the back, but it also had a reverse curve of speed there. So if we look at where the patient was, and the patient came in because they broke their tooth. So you can see how that was overclosed, and Mark, I bet you get a lot of those. Yeah, I lived in the South, and the people in the South, they just don't think things wear out ever.
No.
So they just use them and use them and use them. And finally they just go, Doc, my nose hair is inside my mouth. What's going on here? I'm like catching it. I'm like, I don't have a mustache because I'm a girl. So
I hate when they got mustaches.
yeah, I know that. So this is actually a case that's going in, looks like in a little while. So, yeah, this is basically the redo of that. And what would I do here where that was worn in? I'll go in and I'll actually reshape the lower teeth a little bit, because I don't want to, grind in weird looking teeth on the top to make them match the bottom. So I do get asked that question too. Yeah, so other than that,
What kind of bone did you use?
okay, so let's talk a little bit about bone grafting here. Let's see where I'm at. All right, so what I like for bone grafting varies a little bit from case to case, and I have a big board downstairs with an algorithm, but this is a good time to record. So you have to look at 4 wall defects. The number of walls of your defect is the most important thing. And then the second most important thing is, are you growing it vertically, horizontally? And then the third thing that are big factors are, where are you going to fail? Meaning that, is this the patient's going to cause a problem? Or are you going to cause a problem? Is the prosthetic going to cause a problem? So one of the secrets you never hear about from all the gurus who teach grafting is that the posterior mandible fails in grafting 70% of the time. You did? No, because the patient's tongue will not stay away. That's the problem. If you could basically put your patient to sleep for 6 months, 100% of your grafting procedures would work. And that's the problem. We can't. And so the tongue is the biggest problem. It pushes on it. I always explain it to my patients this way. Why would a doctor put a cast on your arm if your arm will heal anyway? To keep you from touching your arm and moving your arm. That is the only thing. And I said, unfortunately, I can't put a cast in your mouth. I would, and you would sue me, but that's the real problem, is that the physicians had the big advantage of, they'll just put the cast on your arm and you can't do anything about it. And you see people do everything with that arm. Throw baseballs, do it, they're going to do much more than that in their mouth. So bone must be able to heal. Anything, even from a tongue touching it, will stop the blood supply, the angiogenesis stops, and you will have a graft failure. So you need to be very, very diligent. A lot of people think that there's shrinkage of the graft no matter what you do. Not so much. And why is that? You see that with bovine grafts because they take so long to turn over. And when they take a lot longer to turn over, more bone has time to come in, so there's less shrinkage because your patient has less actual time to keep destroying it over and over. So the faster resorbing grafts are great because they turn over the bone quicker. They usually don't need a membrane of any kind for any reason, but you can't have very many walls of your defect. So a 3 or 4 wall defect is all you want to use for like a calcium sulfate, which is one that I use a lot. But it is ideal for socket grafting because you have a 4 wall defect every time you socket graft.
Grab that box back there.
Yeah, some
The brown
here. It's red. It's red and gray.
I'm sorry. This one.
So I'll talk this Ogma here. I actually use the Ogma. I do like it. Let's see, I'll show it up here. That's the Ogma material. So the difference between this and some of the other calcium sulfate grafts is considerable. This is a biphasic. So the biphasic basically means that it's going to heal better and in a different way. I don't want to get too technical with it, but that's essentially what you need to know. There's also, if you look, this liquid. So when you squeeze it together, the liquid compresses into the calcium sulfate, which is the white material there. And then that gets extruded into the mouth. That's your hardener, okay? So this will harden up very quickly. You can sculpt it to a point to get it where you want. Sinuses and socket grafts are ideal for calcium sulfate type grafts.
I used it with bone, mixed it with bone in the last one I did.
And the reason you would mix it with bone is so you have a slower turnover because this turns over rapidly.
Right.
So I know the owner of the company and I'm always honest. And this is great, but it will not work well for tall horizontal or vertical grafts. Okay. So I love this in sockets. I love this in sinuses. If you needed to grow 1 millimeter bone in any direction, it would be fine. If you need to grow 3 or more, I would not use this product for that reason. You could mix it with some other things. So if we talk about slower turnover, then we can go to the allografts, right? So the allografts would be your cadaver bone.
Grab those other 2 boxes back there.
And that is going to have, your normal 4 to 6 month turnover time. It looks like I have ALA. So this is cortical. So these are both cortical. So there is some false thinking out there that you can pack your graft too tight and you can't get blood vessels to grow in. So your graft will work. That's absolutely false. If you can see a blood vessel, you let me know inside the bone. Because you know what? All you see are the little tips of it. The blood vessels are so tiny, you cannot pack graft hard enough. So cortical graft, you can pack, it's much harder, so it means it turns over slower, right? Where if you have a canceled cortical graft, it turns over a little faster, but it also, like bovine graft, holds its volume better. So we call it a volumizer. So in bone grafting, a volumizer is something that holds the shape and size longer, like a bovine, which some people say it never turns over, you know, and you do see bovine graft that never turns over, but for the most part, you will see new bone grow between the bovine graft, and that's really what you want. I use a lot of cortical graft. This is the 250 to 1000 size. I think that's a pretty standard, you know, size that everybody uses. And with that size, the shape of those particles has plenty of room, no matter how hard you pack it, to allow blood vessels to go in. So I use mostly cortical. I will use some cancellous if I wanted to turn over, but if I wanted to use cancellous, then it would be more like a calcium sulfate graft, and it's going to go fast. So I would just use that because, frankly, it has a little bit better working properties. Most companies will tell you to put a membrane over your allografts, although it is not required. So you have to remember that a membrane is a biological barrier to healing. So the membrane, I'll get to it in just a second. So the times when I like to use membranes, okay? You guys okay if I go from grafting to membranes for a minute? Okay, so I use that synopsis graft. It's a little tiny piece of chorion membrane. It's been 100% effective exposed in the mouth. Most of your other grafts, they'll say they can be exposed, but you don't want to expose them. They frankly say expose them all you want. It does have a lot of growth factors in it, which does improve the healing rapidly. They also stamp a little tiny smiley face in it, which is super cute. Makes me want to use them. So,
They are kind of cute.
So what I do is when I don't get primary closure, I can get primary closure anywhere. I'll show you how to do that if you want. But when I do that, a couple things happen. One is it's going to put more pressure on my graft underneath. So I could shrink my graft by the additional pressure. When I do GBR, guided bone regeneration, we typically do get 100% primary closure because we want rapid blood in the supply growth into the bone so that that stays where it's supposed to be. So if I have a little perforation, let's say I have a molar and I can close it to about 3 to 5 millimeters, at that point, I will put in one of those little chorion grafts, and then you'll see they're kind of like a yellowish brown, and that will stick through the top. And usually within 10 days, that'll be pink tissue growing through it. So those are actually quite nice. And then, of course, we can always talk about the Teflon derivative grafts, you know, your Cyto, whatever you want to call them. And like a GBR, they actually have titanium mesh inside. The titanium is meant, why? To keep pressure off of the graft. It's not really for anything else. So you can buy it with or without the mesh. And without the mesh, that's when you have it completely exposed in the mouth. The issue when you do this is it's a dirty, ugly procedure. I don't know if you've used a lot of Teflon grafts, but you sew it underneath, you can see it white, you know, but what you don't see is at the 3-week mark, basically there's tissue growing under it, not over it, under it. And so when you take it out, it's got all this yucky granulation tissue, but that's really what you're trying to get. Some people say you must remove it 3 weeks because it's a biological barrier to healing. So it's better to do that. Other people say you wait until 6 weeks when it's pretty much completely healed underneath. But in any case, you know that you have a big hole in the bone or a hole in the tissue after you're done because it's lower than the surrounding tissue because it was underneath it when it started. Now, most people believe that when you put this in, the tissue grows over the top of it. That does not happen. You actually take it out and the tissue grew underneath it.
Mm-hmm.
And so that's why you get these weird looking ridges and you never see those pictures on Facebook because they don't look pretty. So after that, you have to wait for the rest of the healing to occur and for that ridge to smooth out. So it's really a way to keep a patient that is very non-compliant from screwing with your graft completely. So that's when I use it. If I have a patient that's fairly compliant, I'll use the little chorion membrane. If I have a patient that's non-compliant, I'll use the Teflon and I bill for it as well. Okay, so do remember that. So I don't use the collagen type products except for in the sinus because the turnover is so rapid that it really doesn't help. So I don't use collagen plugs. I don't use collagen tape except for in the sinus. And that's more just to keep the sinus membrane away or repair it so that I can get graft. Now with PRF, I don't really use it at all. Okay. All right, so going back to the grafting. If I need to grow some volume, then I'm going to mix in some bovine with my allograft. So I'm going to get some turnover, with more turnover with the allograft. I've gone into an extraction site where I used allograft 2 later and still found allograft particles. If you graft enough with the stuff, you will find it. Just opening up the tissue, you'll be like, oh, you know, most of it's turned over, but a lot of it didn't either. Seems like the stuff that's more near the occlusal direction will be less turned over than that's farther down where there's better blood supply. So there's Ernesto on the East Coast. I think he called it the SMART technique. And it's basically a pinhole graft that's a buccal onlay of graft material, and it uses bovine mixed with PRF. And so he will put his implant into that, I believe, within 3 months, and he has very good success.
Does he perforate the bone with that?
You can if you can reach it, but the maxilla I'm not too worried about perforating.
Mhm.
If you did the posterior mandible or anything that was necrotic, you would need to perforate the bone until you got bleeding.
Mhm.
So Sam Lee teaches the MIT technique, and we basically go in there with a bone scraper and perforate the bone and get it bleeding with like a bone scraper. And so it's just a matter of the more perforations or, you know, grinding of the bone, the bigger the pinhole has to be. You have more bone and it's invasive. But I listened to Craig Mish give a talk, and he basically called Ernesto's technique the dumb technique. So I don't necessarily believe that myself. I have seen a lot of onlay grafting work quite well. And, you know, as far as seeing it out 10 years, I haven't seen it out 10 years with Ernesto. But I have seen, you know, things he's published and shown where they do look like they're good. And it does look like the bovine PRF graft work. So there's not a lot of research that says that PRF is a huge aid in bone healing. So it's really for tissue. But if you take basically stem cell blood, which PRF has like maybe maximum 3% if you draw it on the right person, the right time of day, all conditions of birth, you get about 3% stem cells. But if you want to get like your bone morphodendric protein, you can actually do a draw of the tuberosity and draw up bone marrow there. And then I've spun it and injected it back in or dipped my bone graft in it, and then you will get rapid healing. But if you're not into that kind of a surgical technique, you can just stick with where you're at. Okay. Anybody have any questions?
Yeah, when you draw out tuberosity, how do you spin it? Same as you would for PRF?
Yes.
Same parameters.
Yeah, I go with the IPRF parameter for spinning bone marrow.
What kind of needle do you use on the tuberosity?
A very, very big one.
Yeah.
Because, you know, you got to remember you need an 18 gauge minimum just to get out of blood, you know?
Mhm.
So, yeah.
I was gonna ask, what's the disadvantage or maybe advantage of using, like, say, 70% cortical, 30% cancellous? You know, you're talking about volume, you're talking about fish, you were going kind of through it all. Is that really kind of the best of both worlds, or not maybe one or the other, or could you explain that?
Sure. Some people say that, so bovine and cortical would kind of be used the same way as a volumizer to, you know, aid in keeping the size of the graft of where you put it. The problem is that a lot of people don't like bovine because they say it never turns over. Well, do you actually need live cortical bone in every square millimeter? Probably not. You just have to have blood supply, right? So you will get some turnover in between the particles. So by adding allograft, which will potentially turn over 100% over time, you're going to even the amount of healing and the speed at which that will occur over time. Does that make sense? Yeah. So the bovine takes a long time to turn over. The allograft takes less time, and you have more. So if you add more allograft to it, you mentioned cortical, then that's going to have a little less blood supply. But if you add more cancellous to it, then it'll have more blood supply and a little faster turnover. So it's like cooking, you know, you cook a little different for everybody. If somebody has a great healing, you know, you can probably use about anything and it would work. If you have someone that's immunocompromised, you're going to want to turn over slowly because that if you go in there, they might even get infection in the first time you start to graft. So you need something that's going to heal over time slower. And so I use a slower healing graft in non-compliant patients or in patients that I'm concerned over their overall health and their ability to heal. Okay. Anything else? Okay, so this, I wanted this to be bovine. And the reason that I mixed this with bovine because I wanted it to stay a long time because I was not sure if I was going to get any flex here of the prosthetic around this implant. Even though I made it non-engaging, I did not know if there was going to be any pushing on this at all. And remember I said movement is the killer of bone. So if there was any movement, I wanted that bovine to stay there a long time so it had time to turn over, and it did work. So if you look, this was in July, and this was 2 months later. You can see I went from this to this. So if you look, it's quite a bit denser all the way around than it was. Okay, and it's not done healing, it's not turned over. So today, if you hadn't have totaled this car by hitting a deer on the way here, we would have taken this out, and that's a 4.3 by 13 millimeter implant. But he has the bone, and I would have put in a wide. I probably would have had to take the bone down a little bit just to flatten it out, and I would have put in like maybe a 5 by 13 or a 4.5 by 15, something so I could get in some fresh bone, cause some bleeding, and I would have put it in the exact hole I took it out of so that it would line up with my prosthetic. And so I need to use the same implant system with the same thread size, and the idea is that I would try to unscrew this. So if there's nothing left to engage, there's a little tiny bit left of the hex. So I was going to give it a shot. Then I would try cutting a straight across the top and using essentially a tool like an elevator that's a flathead screwdriver, unscrewing it that way. If that didn't work, then I would chop around it with like a 957 burr carefully. And then I would keep going until I could actually luxate the implant. And then once I can luxate it, then I can definitely unscrew it, even if I have to unscrew it with a rod shear. But you must maintain some threads so that you can line up your next implant in the exact same location. And at that point, I would have this abutment in my hand, and I would keep trying the prosthetic on with the abutment until I got the height exactly the same height that it was before when I took it out. So then I can reuse the same prosthetic, same implant, everything.
You cemented that. You said
Yeah, I
the
was just
flexible
gonna say.
cement. What did you use? Duralon?
ZOE.
ZOE.
ZOE is my go-to because eugenol is very bad.
You like Final
I'm sorry?
cement?
That is a ZOE.
Yeah, no.
Yep. So yeah, I do like Final.
Mhm.
It's considered a permanent ZOE cement. IRM ZOE cement. IRM is intermediate restorative material. I was in the Army and we developed IRM. Basically, you could pack it in the tooth on the battlefield and it makes the tooth stop hurting so you can keep fighting. That was the initial use for it. That's why you can use it for sedative fillings and everything else too. But IRM basically just has, think of it like a fiberglass reinforcement that makes it a little harder. That's the only real difference between that and other ZOE cements. But eugenol is really the key. It's clove oil, you know, and then it's bacteriostatic. So if you have a little bit of extrusion, it does not cause harm with tissue. That's the coolest thing about it. And it shows up really well because of the zinc oxide in it.
It is
Now you
cool.
take an x-ray and see if you left any, and if there's a problem.
Yeah.
But I have 2 patients that have not, one came back one time, and this lady has in poor health, and she's like, I want you to cement my denture in on my implants. And I was like, no, it's not really a thing. And she's like, no, I want you to do it. She's like, you know, I want to have a couple months of quality of life. And I was like, well, what's safe to do this with? And I thought ZOE, because I can get it off if I have to, and you know, whatnot. And I thought back, well, Sendax did it, you know, he cemented that first one in. That was the whole point when he did it. You couldn't take that out, and it was 25 years in the mouth. And so I said, well, you know, I'm not smarter than Sendax, so I'm going to do it. And so I cemented it. 2 years later, she showed back up because it came loose. And I took it off, and I have the pictures of the tissue, and it's flawless.
That's right.
So I've got 2 people. You can cement them if you need to. And I have cemented 2 dentures onto the mini implants with no housing, nothing, and it stays in solid. And you still can get it out. But ZOE only. Don't try anything else.
So how do you get it out? Yeah.
It's just like anything else, a crown bridge remover. You know, a little
You just
sliding
tap,
sledge.
tap, tap.
Yep. But in her case, so the other one never came back. I think that either they passed away and I had lifetime success, or it's still perfect and they don't need a dentist anymore, you know?
Mm-hmm.
So, but I did get to see the one, and I do have the photos of
Were they bottom dentures?
Yes,
Mandibulars?
they were. In both cases, they were. So maybe they all fail on the top. I don't know. I can't say. But in the lower, I can say I have 100% success with it because I assume they both passed away. Because I have not seen the other lady back after the first 2-year mark.
If it went so well, why don't you do more of that?
It's not standard care.
Well, it is the standard of care if somebody else is doing it. So now that I've all told you, you all do it.
Well, that's a good
It
point.
became the standard of care when Sendax did it. You know, it really did. So we know that it works. He did not use ZOE. I just was a little bit more you know, if this was going to fail, how would I fix it, and what would I do to make it fail the least? And the ZOE was my idea, and it did seem to work perfectly. So I have the mini implant textbook here that show that first case, you know, where he cemented it on. And if you look at needle implants, they have the same success rate as conventionals. They're still doing research on them. They're the ones that people are all posting on Facebook saying, oh, they got nailed. Titanium implants, and they are sharpened. You drill a hole, you put it in, you bend them all, and there's like 20 in a jaw, you know. So, and they prosthetic get cemented onto them. There's many cases where they bend 3 and cement a single incisor on it, and you'll see them out 30 years and they're fine. So there's really nothing wrong with doing any of this. It is standard of care. Why haven't I done it more? I guess I'm just stuck in my old ways. You know, I don't think there's any reason not to do it, and I don't see any reason why I wouldn't do it. And if I had to go to court and testify for somebody, I would say it's absolutely the standard of care, and I see nothing wrong with it. Because I can point out so many different cases, particularly needle implants would be the standard, where they are still doing research, they're still doing them actively, especially in India, and they do show the same success rate as conventional implants over long periods of time. And they are so non-invasive. You can literally remove them at any time if you need to, because they are smooth, there's no threading on them. So Sendax is really quite the genius, because he took the idea of the needle implant, which was out before them, and said, well, I'm gonna, you know, use this Brandemark thing, and I'm gonna put threads on it, you know, and I'm gonna make it analog. So everybody thought, this is genius. We're gonna go from this bendable titanium, which takes long time to integrate and still bendable, and we can put it where we want it. It's gonna stay that day, and we're gonna make it an alloy, so it's harder. So Sendax advanced the idea of needle implants to a point where it's almost like a Brandemark style. And that became the new standard of care, you know, because people wanted a threaded implant so they would know when to stop, so to speak, and to have initial stability. Whereas, you know, in a lot of the other cases, they were still welding them in place. Okay, patients ready? All right, well, I guess we'll pause for a little bit and get the patient in the room and get started again. And then, Robert, I apologize. I took your camera and moved it, so you'll have to move it for our patient here.
No problem,
So
sir.
what I'm going to be talking about, what you're going to see next is how I extract full arch teeth.
Okay. You're talking about.
You'll go back.
There you go.
Let's push it back a little bit.
Hey, you get the gold crown? That might be worth something.
Hi, I'm just observing.
Where are you from?
I'm from Iowa.
Oh, that's okay.
Dubuque.
Me too.
Yeah.
You know what Iowa stands for, don't you?
What does it stand for?
Oh, I'm not gonna say.
Oh, you're not gonna say anything.
Without wandering aimlessly, yeah.
It means beautiful land, and
There you let's see, I went over to Jackson, Esterville, going off
Okay.
West Bend, back.
Okay. Cool.
North American Wholesale.
Well, I have a condo in Okoboji,
Oh, yeah.
so I come up there to stay, and then
Yeah.
I just drive over here.
Sure, I
It's
used to do flowers.
hour and a half. It's not a bad trip.
Yeah.
Yeah.
Pretty comfortable.
Nice lakes there.
Mm.
This is all being recorded, huh?
We're doing a little bit of live recording from YouTube, and I'm doing a Zoom kind of an informal, what's going on around the office kind of thing, and commenting as we go.
Okay.
So we're doing both.
YouTube, huh?
Yep, you're gonna be on.
You're on YouTube and Zoom. Hey, Rod,
Right.
I'm back here, and I'm wondering if I'm going to lose my connection again.
You run a risk.
You know, do you have those little boosters, Wi-Fi boosters that you can go from room to room?
I know what you're talking about. We
Yeah.
don't have one at the clinic.
Okay.
It's available here.
That's a rare person.
Well, if I go in there and then get out of there quickly, I don't lose my connection.
Yeah, the steel on top of the X-ray
Right.
area causes.
But if I go back there for any length of time, I'll lose connection.
to the Wi-Fi.
Yeah,
So we'll have to get you a Wi-Fi boost next time we do this, huh?
I think so.
There's a
Are they
Best Buy
portable?
down the
Are there
road.
portable ones?
There's little pod ones.
I put one at Dr. Brower's shop where the lab's gonna be, because it's long and you can't even get a signal
Yeah.
inside.
So,
I know what you're talking about.
Yeah.
I've never put one here because obviously normally isn't an issue.
Yeah.
yeah,
That might be something, since you do a lot of video and you might just want to get yourself a little.
yeah.
pod.
It'd be nice to
I
have.
don't honestly know how much they cost. My brother has one. Wherever he goes, he sets up his little pod, so he has
Yeah.
instant Wi-Fi wherever he goes.
So what are we doing here on this procedure?
We are removing all his uppers and he has some root tics on 18 and 21.
Okay,
And
And
he does
then-
have some,
then you're going to go ahead and put in these immediates.
yep.
Any implants put in today?
No.
No. Just going to do the extractions and the. Now, is that his old parcel there?
Nope, this is his new one. We'll deliver today after his 18 and 21.
What are the
are out.
class that are open there for?
I think a tooth broke off
Okay.
on Lab's part.
Oh, the lab, okay.
Yep,
All right, very good.
but he's keeping that tooth, so.
Okay, cool.
Yep.
I love this table. I got one, like this table here, but it's not as big as yours. But I just love the fact that you can move this in and you have just about everything ready to go. It's a really, really amazing system. And then, your implant motors and stuff are over here.
Yep.
So it's a nice system. You got to have an operatory that's big like this to do this kind of thing. I'm thinking this is at least 14 wide and maybe, I don't know, possibly 20 long, 20 feet. So it's just a great thing. I'm just talking to people who are interested in, in the future doing implant dentistry. You want a lot of room in your operatory. You don't want a lot of constriction.
Alright, so he knows,
We won't take a case if there's no money. So I'm using, if you remind me, I'll talk about legally mine data. And essentially what it does is it makes it show that you have no money. So no attorney will ever take a case against you because you have no money. Because if there's no money for them to get, they won't take the case because it's contingency always.
What's it called?
Legally mine.
Legally mine.
Yeah.
What is that?
I'll really look
It's
forward
an
to
attorney
hearing that.
service that goes nationwide, and essentially it's the legal way to protect your assets and put them in a sheltered way so that no one can ever touch them but you.
Including your.
Like, I'll give you an example. So in South Dakota, we have what's called the Homestead Act. So your first $1 million in 1 acre of land can never be taken from you for any reason. So my home is $1 million and 0.97 acres. There you go. So that can never be taken from you. So you want to invest in that because it cannot even show up on a search for your money.
And that's probably different for all states. So you get on this.
No, so the way, that's the one thing for South Dakota. So they'll,
Right.
if your state has whatever rules it has, they'll find out, they'll use that first. And then the remainder of your assets get protected through basically a sheltered account through last.
Personal assets.
All
They're just
assets,
soaking in there everywhere.
all your assets.
So then what about malpractice?
That is an awesome legal defense.
Well, your malpractice
We have
insurance just
this,
pays so you don't have to
awesome
defend. I mean, do you want to have 10 counts against you?
The actual surgery.
So your malpractice, really all your malpractice does is it just pays for your attorney to defend
So
you.
you can breathe.
He said, I have 4 people I'm defending right now.
Some people will
And
say,
so far, I've never had to go to trial. Every time they get the reports, I get, so the good part is since they attack, I get their reports, and then I get to see what they wrote, point out why they're wrong. Usually it's oral surgeons who are not smart enough to realize you can't testify on prosthetics because your practice is limited to oral surgery. So stop telling someone that their crown is right or not right when you don't have a clue, because you don't do crowns. You can't testify for procedures you don't do. It's like an endodontist testifying for an orthodontist. You cannot do that. So, but they think they can. And so anyway, you have to point that out, that their practice is limited to something that they're testifying guessed, and then really it's just a matter of most of the people have no training in whatever they're looking at. So that to them it's wrong because they have no training in it. And once you just point out that you have no training in it, would you testify as an orthodontist? No, you can't because you've never been trained in it. So why are you for this? And so they usually realize that they're wrong when you point that out. Usually they have to get to deposition and go, okay, well, show me all your CE credits and your procedures. Oh, you have none? And you've never taken any training since you graduated from your residency program, except for in what you're doing. You have nothing. So for 20 years, you've only taken what you needed to know to do your job, and you're testifying against another practitioner who has lots of CE credits in this procedure. And you have to do it.
You're with a good doctor, so no, I wouldn't be.
I actually had
Yep.
I
Um,
told you about
I don't remember that you're on antibiotics.
this guy. This guy. So yeah, we had dinner together. I don't remember where that was. It was probably an implant meeting. So I basically go 3 millimeters in the tissue in the vestibule. And that is it. No blocks. And we say if it's white, it's right. You see us turning white. What's that?
Oh, he was saying how good the market signal was at this point.
Oh, yeah. Well, that's true. But we're up north, so it's normal.
It's like when I tell ladies to chew like a cow in Texas, they can't get it. I can't say that to me either.
Yeah. So this is kind of the precursor. I'm just kind of so these under the lip are just no fun. So just depth of the vestibule. About a third of the part per kind of area.
Ooh, that's right.
When you're doing a full mouth, you have like a max anesthetic that you're.
Depends on how long the surgery is.
Yeah.
So for me, yeah, because it usually takes me about 12 minutes. So yeah, it depends. Like Marquand's 12, Lido's 10. You can look at the charts, but for the most part, that's what everybody says.
But when you mix and match like Marquand and Lido, do you do 12 and 10 of each, or do you happen to?
12 and 10 of each? No, I'm talking like, I'm probably going to give them 6. You'll see exactly what I get.
I do a max of 1 for 20 pounds. I found that that's safe. I guess yeah, for 200 pounds.
Do you differentiate between whether it's Lido or something?
Can you fix the camera in a second? I'm ready.
I just use Lido, but it doesn't take me that long year. But I remember doing all the math at school and staying under, even for pedo, you're okay.
So on the lower, I know right where the mental nerve comes out. So I'm actually going directly for that. Do a tiny bit of oil and buckle. And open really big. Even bigger. Thank you. Yeah, when people miss the IA, it's because the patient doesn't open big enough for you to lay it down to get it up high enough.
Dr. Brower, do you want your camera up there focused on the patient?
Yeah, Rob is waiting for me, so I'm going to give him the anesthetic. I'm going to let him do it. He's chomping at the bit like a madman.
So ready to do that. Was crazy.
All right. Well, that's what the arms are for in the chair. That's the only reason I put them there, That's right. That's why they're short, so you can't get enough of a, to push on and do anything about it. So the only time I ever give septo is on lower molars because it's proven to only be clinically more effective there. Otherwise, lidocaine works just as well.
That's what I do too.
Yeah, so it's the only place that I give it because otherwise, people think it works better. It doesn't. It's twice as much anesthetic. That's why you think it works better. There's twice as much anesthetic in septo as there's lido, but it's also twice as much money.
You just lay down, you're laying septo on the buckle? When you say lower molars?
PDL around it and then
Yeah.
the lung buckle.
Okay.
So infiltration, there's some infiltrative effect with septicane. So septicane, I know an old surgeon in California who only does, he doesn't do blocks. He only just does intraligament. And you can, but so in this case, I just added a little bit. Are you starting to feel tingly on the top?
I do that for all my crown and
What's that?
and filling bed.
Okay, I'll poke you and you tell me.
I just do a wooden buckle.
How you doing with that? Yeah, John?
With the 30 gauge, just squeeze it.
So that was the first thing right there that you guys saw.
I use a little card just to.
So Mark, to answer your question, I don't think I've ever used 10 cartwheels of anything in my life.
Okay.
So, so normally it'd be 3 Lido for the upper jaw.
Okay.
Is that a Marcaine there?
It is. Yep. And he's done because we buffered it. So we know that it works better for the infected teeth, and it's also effective in about 20 seconds.
You buffer all of it, or just?
Well, we usually do the Lido, and the Lido almost every time. Septo it acts pretty fast, but if you buffer it, then it basically stings less going in, and it's effective in about 20 seconds versus 4 to 8 minutes. You know. Okay, I'm gonna sit you up and let you relax.
Unless you draw from the hat up and
You did great. You can go ahead,
Attempt to
Rob.
see
You don't have to write down. As soon as you write down what you didn't see, then you're responsible for writing down everything.
Okay.
And that's why I don't do that. So you're responsible for everything, but as soon as you write down one thing, it's like if you put in within normal limits, you know, like on an exam, it means you did everything and looked at everything. And so if you do that, then you're responsible for everything, right?
Okay.
Whereas what's the reasonable burden that a doctor would have to do an exam? Well, oral cancer, caries, perio, but do you want to be responsible for anything else anybody can ever think of? I don't. So if you have that CT scan, let's say there's a couple of little mild radiolucencies, what would you say?
Then I saw radiolucencies in this area.
Well, how many and where are they? Then you're required to write that.
Okay.
And then if you write how many, then are you required to follow up on them? Yes, you are. And then if you write that, are you supposed to say possible differential diagnosis of multiple myeloma?
Right.
Yes, you are.
Okay.
So I'm starting to figure out why
Yeah.
we say legally vague, meaning that as soon as you start to give too much information, then you're required to put everything down. And we've kind of gone back and forth with this. My med mal attorney deals a lot with physicians, and so he has a huge burden with like Medicare. So Medicare says that you cannot use an auto note, okay? Because that means you didn't do any of it. So the feds have gone after him and said that if you use an auto note, that means you're lying because you can't do all that on every patient, right? Because they're different patient appointment lengths and your note still said the same. But then he says that if you don't include that, then your notes are wrong. And he said, but they will argue both sides of that all the time. That you can't use an auto note because your patient lengths of time for your appointments were different. And yet you must have everything that's in that auto note or you're wrong for the procedure and it's below the standard of care. So it's a tough thing. So legally vague is what it actually is. It's legally vague. You don't know exactly what you're supposed to do. That's why the state boards will not ever, and I can tell you in all 50 states, there's no rule, law, anything that says what's required in your note. Nothing. But I can tell you that they all have certain guidelines. They all meet as a group every year. The state boards do. And they talk about what it is, but they will not share that information with you. So I'm licensed in California. And one of the things that I think that is good there is that they require you to take your jurisprudence test every 2 years because they can change the rules and laws at any time and there's no notification to you. So if you don't know and you're breaking the law because you didn't know, they say that, ignorance of the law is no excuse. They really believe that. And so that's a problem that the burden's always on you. I have 3 licenses, so I'm required to know 3 different jurisprudence. And they're very different based on where you are. But I think that we all want to follow the rules and want to not break the law. But when we don't know what they are, because they're not directly spelled out, it's difficult. So they play the same game of being legally vague. I have point blank asked my state board here many questions, and they just say, please refer to your state rules and regulations, and here's the code.
That's what they
Because
do.
they do not want to define it either. So that is the problem. So you have to play the same game that they're playing because you're forced into it. We all want to follow the rules, but they will not give us the rules to follow. So they give us guidance.
Give us an example of legally vague.
Extra-oral exam, EOE. So I did an extra-oral exam. That's legally vague. Yeah,
What is EOE?
extra-oral
Oh.
exam.
Gotcha.
Yep. So IOE, EOE. So all of these are required to be in there. So what does that mean? Well, it should mean everything, which you can take it at a glance, but then do you want to get into that thing where I check them for melanomas, I check them for squamous cell carcinomas, I check them for basal cell carcinomas, I check them, for masseteric, hypertrophy, I check them for their lymph nodes, it's an extraoral exam. So the problem is you have to say you did it because you did do it, but can you afford to actually break down what that means into every single thing every time? Well, the auto note becomes incredibly long, and then the real information gets lost in there. So that's legally vague.
So I was just gonna ask you, when you look at this, I mean, do you look at it, because you do so much legal defense work, do you look at it more from that standpoint? I've always looked at it just, I'm a dentist in a small town, and I've been practicing 20 years, and I kind of think about it like, if 12 of my peers were sitting in front of me, is this logical? Does this make sense? Is there a way to go about this? And that doesn't really work so well for a lawyer, but I think it would work good to the state board. It's kind of the way I think.
It doesn't. It's all just like the rest of the world. It's all opinions and what you want to believe. And so the good example is Dr. Grant Lemke last year in Wisconsin gets sued by the state board. Oral surgeons and a general dentist said, this is not right. You can't do too many implants from interlock with the molar. So the state board goes and says, well, these aren't FDA approved. And there's some research on the, what the FDA requires. And basically 2 dentists came forward against an oral surgeon who was also a prosthodontist, which the board hired to testify against this doctor, as well as, the initial dentist who wrote in his notes in huge capital letters, this is all wrong. This should not be done. It's below the standard of care. It's malpractice. So the state board and the oral surgeon and prosthodontist lost their case against Dr. Lemke because 2 other general dentists came forward and said, I've been doing this for 20 years and it works fine. And at that point, they argued about, well, the FDA and the judge said that it's not for her to determine what the FDA regulations mean. But in this case, the doctor did not fall below the standard of care and is therefore not breached his, duty to the patient. But the board and other peers felt that it was wrong. And so he had to find other peers that said it was not wrong. And that's where I come in is, I'm open-minded. I have training in all the specialties. I've trained almost all of those with other people. And you have to understand that just because you were trained one way doesn't mean it's right, doesn't mean it's wrong. And if there's something you see and you don't understand it, you don't understand it. It doesn't mean it's wrong. It just means you don't understand it. Go get training first. Once you've had your training, if you want to say it's wrong then, I'm totally fine with that. But you have to have a reason other than, I don't understand it, so it must be wrong. Okay? Any other questions on that?
I see a lot of that.
Yeah, I think so too,
It's all over the place.
It's, I think the next generation, these millennial dentists are going to be thinking gold work is wrong because they haven't seen it, they haven't seen it. And that's the thing, they don't get to do it in school anymore. They see it out. And so if someone walks into their office with, 12 new gold inlays instead of, CEREC crowns or fillings, I can see the next generation saying the gold work is wrong because it's like blades. They work great, but you don't see them very much. So now people think, well, because you don't see them, they must be wrong. That's why we must have moved on. Things come in and out of fashion. That's really what it is. And rightfully so, we do try to do new things and try to improve. And so at those times, we make little tiny incremental steps of improvement, but sometimes we forget where we came from and, have huge failures. In the lab side that I have, I see that big in digital. So everybody digital, but yet you lose the ability to stack porcelain as a ceramist when you do that. And there's like 1 or 2 schools left in the country for lab technicians now. They're all gone because everybody thinks I'll just, buy a multi-layered, zirconia puck. And as you know, Dr. Cribbs, getting those shades are difficult.
Very hard.
Even though I had another doctor, Tyler, send me some cases and he wanted fluorosis. And I did those crowns 3 times because when I painted on the fluorosis, it would soak in deeper or shallower, and I had to get a finer haired brush to put on the fluorosis spots. And then when you look in their mouth, they have 1 tooth that's this shade on this side, 1 tooth that's this shade on this side, you split the middle or do you pick one or the other, you know? And so there's a lot of art and science, and so a well-trained lab technician that's analog can do that, but digitally, no, you're not gonna be able to do that. And so that's, you know, I see the next generation saying we're doing it wrong because, you know, we're doing it different. It's like amalgam. Everybody, you know, when I got out of school, you know, almost 25 years ago, amalgam had taken a big heat. A lot of dentists, they were going holistic, had lost their licenses by saying it was wrong and telling people you're all sick because of these amalgams, so you have to take them out. So they lost their license for saying that was what was making the patient sick. And now I see people still you know, we all know if you've been in dentistry a while that the amalgams last longer. They just do for lots of reasons, but they don't look right. You know, people don't like the appearance of them, but you know, gold lasts the longest, and people like least, it seems. I don't know, but I do see each generation finding the previous generation wrong. We were all trained with G.B. Black, and I collect old textbooks. There's an entire textbook written by G.B. Black's enemies about why all of his techniques are wrong. A textbook on it. So you can imagine that this is not news to anybody, and it will never go away. The next generation will find something wrong, and we will find something wrong, you know. So, but my whole shtick is just, we're all right. We just don't understand why the other person is more right than us today. But we can get there. It takes time. So, yeah. There's the porcelain oven is in the corner for stacking porcelain. I was showing them how we use the pink composite to do like the, you know, the colored prosthetics. Downstairs for me, there's, you know, like the whole lab. It's an ExoCAD 3 shape. It's got all the mills. You remember Baldy? Yeah, so Baldy sold me an extra set of his equipment because he was upgrading. So I bought some of that from him, and I bought all pieces of my own. So. I don't do anything. I go home and go to bed.
Oh. That is so not true.
Yeah, I'm fairly busy. So.
Josh
but
never suffers from boredom.
I do not suffer from boredom, you're right. So I have a place where I built room for a lab, but I like having a queue because I can go in between patients. Like we have a no-show like this morning because of a car accident. So it's nice to be able to just to go and get rid of my boredom. So, all right. Does anybody have any other questions right now?
So just what's a quick example of after you rate a scan, what you put in there?
Evaluated CT scan.
Okay.
Yeah. So the legal standard of care is this for X-rays, and you should all record this. If you're ready, record this.
Hang on.
This is important, and I can show you. I have the top 10 reasons why a guy who's done over 2,000 dental board malpractice cases will tell you these 10 things are why you will lose. Okay, and so if you take an X-ray, everybody ready? You must do 3 things. Why you took the X-ray must be documented. Okay, because there's been dentists who've lost their licenses for taking X-rays that were unnecessary. Okay, just for billing purposes, Medicaid and Medicare will go after you for taking unnecessary X-rays. What you saw on the X-ray. Now that is the caveat. What you saw depends on what you did. So you must record what you did based on what you saw. So you must have those 3 things: why you took it, what you saw, and what you did based on what you saw. We took the CT scan to evaluate the implant placement of number 18. Implant placement is good. We will evaluate future treatment based on this CT scan to see if there's any future changes. Those 3 things cover you. Okay? So those 3 things must be in every note. If you take an X-ray, a biting, a PA, you better have all 3 of those things in there, because if they're not, you are below the standard of care. And that is required, because you have to have a reason why you radiated somebody, and then what you saw, meaning you did take a look at it, and then what you thought or did based on that. So there's an abscess on the bottom of this too. There's caries. So in the medical field, they have a diagnosis code. In my lifetime, we will see dentistry go to diagnosis codes. And you can see it in a lot of the software now, where you can click the diagnosis of, why do I need a DL? Because it's fractured, or it's missing, or it's caries. So you click the diagnosis code at the same time. And that covers you. What do we have here? I'm getting it. You want to tell me what it says?
Yes, sir. David hit is also right.
Okay. Will my assistants want to take care of me? All right. So anyway, is that helpful information?
Yeah.
Okay. Yep. I have a thumb drive with a lot of information on it, and our personal attendees here can, I will get you copies of things on the thumb drive if you want, which include like my denture manual.
Okay.
You remember from that course?
Yeah.
And then there also are my consent forms, and they're editable on my consent forms. My consent forms are based on the 10 biggest implant case losses. So they cover every reason that was given why the judge, the jury, or the attorney said that this was wrong.
So you just want us to bring a thumb drive? Is that?
No, we can, we'll put them in a shared folder for the group, and then Rob can send you a link to the folder.
Awesome.
But I'm only giving it to the attendees here.
Okay.
So,
That's a great perk. Thank you.
yeah. Anybody have anything else?
What are we doing on this gentleman in here today?
We're going to take out his upper teeth. And so what I want to show you is my technique for taking out teeth non-invasively. Kevin, I know I sent you some videos. If anybody wants any like private videos, I've recorded this hundreds of times. But essentially, I'm going to take a burr and go interproximally in between the teeth to get to the center of rotation and resistance, if you know your orthodontics. And I'm going to use my elevator down there. If I use it up high, I'm going to break the tooth off. So by getting it down low, I'm actually luxating the root up instead of the tooth. So when I do that, I'm also doing the alveoloplasty at the same time. Because if you think about it, all the little projections of bone are the peaks where the papillas are. I'm removing those at the time. So I'm doing the alveoloplasty at the same time as I'm doing the bone removal that's required for the teeth to come out easily. Okay. Then I'm thinking about the grams of value in my head of how much does it take to move a molar, like the 500, 600 versus, a canine might be 500, 450, whereas a premolar might be 350. So you have to have more pressure pushing from one location than to another. So I can't take 10 incisors and push on one molar, you know what I mean? Because the first incisor will break. So you have to kind of push back and forth. And so I use one tooth to luxate another. I don't start taking them out until they're loose, if that makes sense. So you're going to see once they're loose, then they all come out pretty quickly. Okay. Other than that, are we going to see let's see our other patient first? And I think the other patient might be potentially a sinus lump. I think we needed to take a CT
From videoing so much?
Yeah.
So PRF is where we take your blood and we draw it out. And we're going to make it into an artificial skin and then put it back. It's going to be cool. So Dr. Lamont has never drawn blood in his life in this baby.
He's a champ.
He's great. So, he's probably got more emergency training than anybody here in the room. So here's your Band-Aid, Jen.
I'm from Texas. I used to be a special ops medic a long time ago.
So
John's
either way,
down at my office.
based on
and
what you want to
I
do.
do it now. You have any
Now I'll
problem
get you,
with some of the images that people? I was having problems finding the veins. So I generally said, if you want to try this gentleman, I think you would find that you.
Oh, I got bored. I'm good.
Yeah, I know. I looked, I thought, yeah, you'd be. You're like me.
Yeah, you think.
Mine are easy to find too.
Yeah. Yeah.
Of course, you got them on the hands too, right?
That depended on the size of the needle, I think, too, because I got one, and I tried to put his hand on the.
So, are you doing some bone grafting today with this?
I think so, yeah.
Okay, and I'm just wondering why we're doing that.
Yeah.
And we're gonna see this almost little white piece of skin, and it's gonna be a membrane. So instead of using like an artificial membrane, that you buy at the,
Okay.
we're gonna use your own. It's not, we know nothing about that.
That's amazing.
Yeah, it's gonna have all the proteins and the things that you're gonna need, and it's yours, you know?
Yeah.
So
Your body likes
it's,
it better that way.
Sure.
Yeah, I think so we get two things.
And then he starts it with the tube already connected.
Yours, no?
No, he does it after he goes inside the line.
Pop it in.
Yeah, and then he adds the tube.
And you pop it in and you.
Yep.
Right now,
Yep.
people are blind people should go watch the CT machine because I'm gonna get radiology credit.
As it comes up, it'll start out really faster at first. and then
I already got it through Sioux.
Oh, okay.
Excuse us.
Next year I'll need it.
Coming around
You know, for
here.
somebody that wants to get rid of the palate.
I'm gonna take an X-ray if you guys wanted to.
But bang for a buck. I mean,
We're good.
lower-
We're
like
fine.
regular upper with like lower implant removal here. That's my favorite.
Oh, I don't mind. I don't. No, I didn't like it with 30 people. That was too much.
Yeah, I can understand that.
That was November 2018, not yet.
Good job, David. Fixing your skills. Gonna go back to the very beginning.
Well, I mean, yeah, a good number. I mean, should I bring the cost down? Exactly.
She sees
And
that Terry has to.
I don't do hardly any restorative dentistry. I did up until this year.
Alright,
I
back
brought
out.
in a guy who's like
Yeah.
60s or 70s, just I just have him do the general dentistry.
Oh my gosh, you too?
I see medication.
You wanna talk about
I
this?
do like
Right now, you know, because,
I'll give it to all.
you know, the emergencies, doing the extraction, whatever.
Yeah, yep. And so he's gonna be looking at, the bone, the lifts he did up here. So we got high enough up so that he's able to see. So then you can see this whole maxillary up there.
We did right here.
Okay. All right, then I'm gonna come, have you take a seat back here.
Perfect. Okay, that's what I was gonna say too.
Yeah, I just talked to Dr. Bar, he's not prepared for more surgery today.
Oh, okay.
So. I'm just gonna talk to him. Okay, so how's it been going with that up there? Is there, did you have any,
There was maybe after the fact, but I still have some of my sutures in.
okay, good. We can find things in the ambulance?
We used to use an 18
We do a bone top, yeah.
That's what a lot of people do. I should be about it, right?
Right.
It'll stop at a certain point. Or it keeps it from clotting.
Mhm.
You know?
So being recorded.
So you getting a denture today, or what are you? what's going- Yeah.
Yeah.
Upper,
You bet.
ventral, lower partial.
Lower partial, okay.
Yeah, you bet.
You came to the right place, that's for sure.
Yeah.
Thanks for letting us watch them.
Oh, that's fine. That's good.
It's like, even though most of us been doing this over 20 years, we still learn so much
Yeah.
from.
Oh, yeah. You never stop learning.
Hopefully. right?
That's why they call it a dental practice.
Yeah. Yeah, practice, well practice.
Well, they usually do. They usually do. You know, if the dentist, they usually do. They're usually specialists. You know, because
They feel superior.
yeah.
Are you on break at work or just heading there?
So I actually got it today off and I'm heading to
We're gonna look at this post-op patient.
next one, so we're doing
Oh,
a paper take kind of mini family get together.
What was the procedure that you performed today on this patient?
we did an upper right crestal lift
Okay.
about 7 weeks ago.
Rob, what time do you want my patient Paula Fulton to be over here tomorrow?
You have a patient coming tomorrow?
Yeah, Paula Fulton.
Paula Colton.
Fulton, Fulton, Fulton.
We might want to do it after lunch. I'll ask you, sir.
Because she's asking what time to come over.
For new patient paperwork, maybe, I wasn't sure if we wanted to do a lunch then tomorrow.
It's up to you guys.
I'll take your advice on this. Here's what we have. So we're starting at 8 a.m. We'll go till 1. We could have her come after, or like have her come at 12:30, and we could, how long do you think the procedure will take?
Well, he's doing 2 sinus lifts, one on each side.
Okay.
And her name is Paula Fulton. So she needed to get sent, fill out paperwork at 12:30.
Yeah, could I have her contact them? Maybe I can directly. I'll just want to verify with Dr. Brower.
Okay. All right. I can get you, let me just get you her phone number here. Hold on. I'll just see if I have it. I sent all that stuff over ahead of time.
I'm sorry, sir.
Yeah.
Yeah.
We take that impression and then that goes to a laboratory and that denture is made and we allow them 4 weeks to fabricate that denture.
Okay, I have her phone number here. She's in town, 618-978-7085. If you could call her and get that information, that'd be good.
Of course, sir.
Okay.
I'll take care of it.
All right.
For a weekend ahead of time.
And then the day of, so you can use Rajah, it's great, but I docs it's now 400 anyway, and it's independent from us. So they get memory loss and it opens the area. There's none of the other stuff. So if I can give it to like COPD patients, really, really sick patients, I would not give more than 100, because it's usually 50 and have heart patients. So 50 to 100 would be a high dose, 20, 25 would be like it's probably an average. Like if I would get any of you guys.
Taking out the sutures.
We probably are. I got it just in case.
So I was thinking, now you'd have to have something wrong with your lungs or your overall health if you make me give you that. Like a female 85-year-old, I'd give you.
Yeah. That's really, I mean,
it should be similar to, well, they have labs that actually online, but they do get some memory loss from it, and it really makes you sleep. Like, okay, Benadryl makes you sleep, same way in this one. So it really, really makes you sleep. Well, like those storage chairs, yeah, they do have to have a run.
Nitrous oxide.
Yeah, my station can't. If I don't take any pill, they can't do my tips in my skin.
That's right.
Everybody. You should ask me, and all you ask me. These are the people that I'm entering, so, you know, I enjoy the stuff. So, Rick, if you want to come around this side, you're a tall guy, so you can actually see quite well. If you look right here, this is a crustal sinus lift that I did 7 weeks ago. I'll just move the implant out of the way, so you can see you can see where the hole was. I think it was an oral antral fistula that I closed 7 weeks ago, and then I had him come back this time so we could see if it healed. And it looks like all my grafts stayed. So this is a 4x8 implant So I will do a slight bump when that is ready to go in.
Will you use PRF there?
I will, and I actually used PRF today. I did this as well. So I like to put the PRF in first because then if there is any membrane showing, it's either going to repair it or stop it from perforating if it's there.
And if it does perforate, you're still good.
You're still good because that's what you use to repair the membrane.
Right.
Yeah. So anyway, so that's, if we take a quick photo, if you guys want to get a photo of this, I'm going to go to the first, we should have a first CT. And we'll see. So all those posts you see me doing online, this is how I do it. I walk in here and I take that photo and I walk down the hall and I post it. All right. So I'm going to go back.
Anyway.
No, you're fine.
Playing that. Okay, I'm going to quit. Now let's see. I wonder if she saved it under a different name because it should have come up there. Okay, so let's see, post-op Crestal. So that went today. So this would have been when he first came in. So July 22nd. So we'll get to see what it looked like before I did the lift. All right.
Wow.
Did you just do that with osteotome?
I'd have to look it up. Yeah, I don't remember that one. They're all
Yeah.
different, you know. Each one I do different based on what it is and what it was for. And I had him come in today thinking it might not have worked. So, but you see how this little septum is not there? That means I likely did it with an osteotome because I used that. Yeah, so that is basically crestal sinus. So you can see there is our hole there. Yeah, there you can really see quite a bit better. Yeah.
Okay.
So I think tomorrow we're going to do some bilateral lateral sinus lifts on a patient of Dr. Down.
My patient.
So that'll be a much more interesting surgery for you to see than this. Crestals are kind of, you know, we've done a lot of them in your office and you can't really tell what you're doing. It's a blind technique, but it's so easy, you know. It's something that all of you can do without much training and still get a fairly good result and not really have much of a chance of harming a patient, you know, in the long term.
With the PRF that you taught me, I made me a lot less nervous. You know,
Yeah.
just go slow and put it in first, like you said.
Did you guys get your 6 tubes?
We did.
Okay, and they're spinning?
Yep.
Okay, excellent. So the one trick with the PRF that you got to know when you get into it is that you want to keep the tubes moving from the moment they come out of the arm, and they have to be in the machine in 90 seconds. If you don't, you won't get any plugs. Okay, so a lot of people don't miss that one thing. So I guess I was successful. So now let's go see the patient in the room because I had the assistant just remove the suture so you can go see what it looks like in the mouth. So this is 7 weeks healing. I have not seen the patient yet.
All right, stand there in this room. It's hard to get a good angle.
You're on this floor.
I like that. I like the shot.
So several months ago, Josh did a sinus lift on you.
September 1st.
September 1st.
Is it all right if I record the exam in you? Yes? Okay, thank you so much. The people that will be seeing this are just dentists and professionals.
Sure. How's it feel to you?
Huh?
It's finally me.
Okay.
How's it feeling to you?
Fine. As soon as I had some today, they were the only thing that was bugging me a little
It
bit.
was your
'cause-
tongue, right?
Well, it was my cheek actually. 'Cause
Oh, yeah?
every time I'd smile real big, I could feel it tug, and then my lip would be sore.
Right.
What'd you guys do?
So you heard him say about his cheek. That's a key indication that I did primary closure, meaning that I had to close it all the way over just to make sure that the little hole I made didn't show no antral. You can get closure. And we can do you can do a lateral pedicle lift off the palate and flip it over. I think I might have done that. So Can you look up in the chart and see if I did that, if I did a pedicle graft on this? So that's what it looks like in 7 weeks. I mean, can I have the air water? The same. So if you look here, you can see the little incision line right there. And that's really the only reason I can tell that I was there. So here's an incision line. The rest of it.
Buckle, right?
You see how it's looks bulky? See how it sticks up?
Where'd you get the connective tissue?
Out. I just rotate it right from the palate.
You just rotated it. Okay.
Yep. So
No,
based on the size of the hole for like oral interfiscial closure, you can rotate, a piece of connective tissue off the palate, or you can take, that's kind of a normal size. You can take like the buccal fat pad out of the cheek if you need to bring it down. But if you do go that high and take that much, then you can actually de-cheek them. And if when they smile, one side won't go up as much as the other. So some people go through a de-cheeking procedure if they have really big cheeks, and like me, and they don't want it there. I just figure as I get older, all this fat will drain where I want it. So I'm leaving my cheeks.
So how large of a space do you need to you rotating that to keep your blood
Just have to
flow?
close the hole. So you just rotate. You basically you fillet it. If you fillet a fish,
Sure,
you
you're so
fillet it. So you
accommodating.
leave the skin, and you take the meat of the fish, and you
Oh, I see
rotate
the
that
line now.
over and cover it, and you suture that down.
Yeah.
So that's my favorite membrane.
So does that
It's
pulling
already got
sensation, let
blood
that go away?
supply.
Yeah, without the
Feels beautiful.
suture.
Yeah.
Everything you
So,
could ever want.
Up until then, only
And
if I
then you
smell
take your
real big.
buckle, Josh, you take the buckle tissue.
Who did your
over the top of that.
orthodontics?
I like to move palatal tissue if I
Utah.
can, but the
Utah,
buckle,
okay.
of course, moves
That's
easier.
interesting.
The palatal
Thank you.
tissue is keratinized, and the buckle.
So it's
sometimes
one or the other,
sometimes
you don't do both.
There's no keratinized tissue on the buckle for you to rotate. You have to take the
Palate.
pedicle graft off the palate. There is nothing on the buckle to take.
Okay, I just meant you didn't like advance a flap from the buckle.
If I needed to, I would, but I would like to advance the flap from the palate. It's harder to do because it's attached. So you have to basically fillet it off so that the skin is mobile, and then you can move it, but it will not move otherwise.
You do a split thickness.
You do a split thickness to fillet.
Yeah.
Yep. So when are we? It's looking great. So the CT looked really good. So I think we're going to be 100% successful. I think we'll just do the tiniest bump the day that we place the implant. So I just didn't know. I don't remember if we set a date when we were going to place the implant.
No, I think you said depending on how this goes, because if we had to do more.
Yeah.
Because I know you had to do two
Yeah.
separate
Can I?
holes.
Okay.
This looks good to me. So we will probably touch it up the day of the implant, but it'll be very, very minor.
Okay.
You won't even know I did it really, because I'm gonna go. It'll be in through the hole where the implant's being placed.
Okay.
So it should be super easy. Yeah. So I would say at this point you heal great, so you could have the implant placed whenever you'd like. It looks good. Yeah. Very, very good healing. Like this looks more like 3 months instead of under 2 for me.
Well, I fall above your orders, so.
That would be why.
We're
Now
like-
I know
we-
why.
Thank you.
Only
Yeah.
water for 3 weeks, no pepper, no sodas, no beer.
Yeah.
Never chewed
Anything
on
that
it.
opens my flap or gets in the hole. Well, that, it does. It looks beautiful. I think that. I mean, you cannot tell. There's one little spot I can see where I made an incision up here near your cheek. Did that surgery? It's that good. So really good.
Yeah.
Although I would totally would never see it. Like it didn't exist. So. All right. Let me.
Dr. Brower,
Thank you. All right, thanks.
do you always want to replace second molars when, is that something that you feel like you need to do?
Well, me is relative. He's young enough that I think, yeah.
Okay.
If he was 60, no, I wouldn't do it.
Good.
So there was a question on when do you replace second molars with implants. So I gave him the correct answer, but I want to hear what you guys. When would you replace a second molar with an implant?
I'm taking open really big.
That's really
I like an honest man.
I don't do any prep. If they truly want it, they send them to an oral surgeon and let the oral surgeon take that on. But mostly I don't. I know
So the short answer is this: if they don't have one, maybe they don't have any of them, and they're 60 or over, then I'm fine with it as long as their occlusion isn't being damaged. They don't need it. But on a young person, I think that that is well worth replacing a second molar because he's got a lifetime of use to come out of the tooth. So that's my real thing is I don't care if they can open bigger or not, but if it's more age related. If they're young and they're going to get that much use out of it, I think you should. You know, I'm hesitant to take out a tooth on a 20-year-old unless I'm taking out all their teeth.
Is there any minimum size implant you'd use for that?
In width, length, or what?
Both.
6 millimeters would be the minimum length I would go.
Okay.
Yeah. So
then you'd
it's
want
plenty
to
wide. So
plenty
you
wide.
could do a 6x6. You know, I think that the one I put on the CT was a 4x8 just to see if I had 8 high and to see how wide I had. I think I have 12x8 is what I have for bone that's available to work with after the sinus. And so, yeah, I think it would work.
So I'm guilty of letting my experience. I blamed my second molar implant back here and I had him take it out and I just didn't replace it.
Last time I think one of the guys brought his implants and was like, got me in the hall. He's like, would you place these while I'm here? So we did.
I'd actually have you take out.
Yeah, you didn't get it in the machine quick enough. That's what I told you. This is what happens if you don't keep moving it and get it in the machine quick.
If you take,
Yeah.
if you take the cap off, you won't get
not,
anything.
this is what'll happen. You will not get a plug. So this one has a plug and this one does not. But what about the other 4?
I think they look like this, not as bad.
Okay, well, that's
If you take the top off for 10 minutes, you might get a little blood.
No, that's IPRF. So you can do it differently, but IPRF, you basically take it off so you can draw it out. And then, so Rick's whole thing about taking the top off is just so he can suction it out. Otherwise, it doesn't matter if the top's off or not. The reaction inside is going to happen. So what's happening is you're spinning it less time, so you're waiting for the fiber to clot. It doesn't matter if the top's off or not. But the reality is that's useful when you're doing IPR, so you can suck it out. That's the main reason to take it out. The top off. But today it's not going to set up any more than it is right now. That's just simply not getting it in the machine quick enough.
I've seen them before though, where you don't have a plug and you leave it for 10 minutes and you come back and you got a plug.
Isn't that what Rick teaches? So what Rick's teaching is the low speed centrifugal theory, right? So that's the whole thing, and that's Shakrin's whole concept. So we actually had I was teaching in Naples, Italy, and Shakrin logged in to give part of the course. It was we were teaching plastic surgeons and elegant students. And so we asked the question, so what's the minimum, right? Why don't we centrifuge less time if this is so good? And he said, because nothing happens at all if you go too less. He said, we just kept going less and less until we got nothing. And if you go less than this, you get nothing. And so you don't get enough separation. You don't get the cells to separate. So that's why this is the minimum you can go and still get something.
What is the advantage of the low speed?
Low speed, you crush fewer of the cells against the sides of the walls. And the higher the speed, you pull the cells farther into the blood clot down below. So you want them to be in the matrix on top so when you draw it out.
So is that a tiny one there on top?
Yeah, you have a tiny one down there.
Okay.
But let me take it out.
So.
Yeah, and that one's actually bigger.
Yeah.
Thursday, the 14th.
I don't think we got them going fast enough.
Did you use that machine?
Well, I don't know what they used. I'm just saying, I saw them doing this, but I don't think we got them.
We put it in that machine? That's the wrong machine. I actually had the machine up over there. Yeah, I told you not to do that. I set the machine up over there for it. Yeah, well, I did it wrong.
Then you have to
That
get,
machine is for facial aesthetics.
you have to get them in with 90 seconds is that
90
right?
seconds,
Yeah,
yeah.
okay.
So then that machine was set up for APRF. This one is set up for IPRF. And that one's set up for facial aesthetics. So I have a preset so they can't screw it up unless they put it in the wrong machine. Which, that's why I walked over there and opened it. That's where it goes. So.
Okay.
All right, so there you go. So we will let them sit because facial aesthetics is less time. So we might end up getting some more separation just by letting them sit.
Yeah, that was 6 minutes and like 24.90 or something.
Yeah, we'll let them sit. We might get some more because they put them in the wrong machine. I thought they ran them at the right speed, the right time.
It's the same type of machine.
That's a horizontal centrifuge. The other ones are slanted.
Why did you want to run it on the slanted machine versus the
So
horizontal?
they couldn't screw it up. It was already set.
Oh,
So, yeah, that one's set for APRF, that one's set for IPRF, that one's set for facial aesthetics.
okay.
Yep, the horizontal does give you greater cell separation. It does. Now, is it clinically significant? Rick Myron says yes. I say no.
Yeah.
So, yeah, and it's also like $5,000 versus a couple $1,000 a piece. So,
Okay.
are you feeling pretty numb on the bottom too?
But yeah, we were talking earlier, but I mean, getting an implant, I think the restorative part of it is so much harder than this one here.
If it's probably the infected one,
Yeah.
it's probably not gonna get any more numb than it is if you keep around it or not.
But I mean, I guess.
Well, all I know is it never hurts me.
But, that makes me feel a little bit.
I thought you'd enjoy that.
So, man, you really onto the word here.
Oh, I don't know. I hired these actors to come in on the weekends.
I don't know about that.
It totally makes my patients look way better than I am. Yeah. And I went to Kinko's and they made all these certificates. I can get you copies if you want. I'll leave part of that. It's pretty cool.
So you gonna live something with food?
I do.
Do you sell stuff or is it all wholesale? You sell?
No, it's called, you can look it up on Google, it's SiouxFallsWoodworking.com.
Okay, great.
Yeah, no, so we sell wood, it's usually like bigger pieces, like, we did the Sanford boardroom table.
Oh, wow.
That's a big piece of furniture. Camera's okay?
Listen to her.
I told you, I don't feel okay. I'll check you ahead of time. You ready to go live stream? Yeah, I would say so. Rick, are you still, feeding our people that are waiting?
Yeah.
Through there? Okay, good. And yeah, Robert, I'd say we are. The way my trays are set up is what I use first to last. So it's closest to me, farthest away from me. Man, are you trying to steal Hannah's thunder? Is that why you're in here?
Well, I've been in here
I know.
this whole time,
You know me, I like teasing you.
I
Don't bring
know.
your safety glasses if you're gonna be
Yep.
chair side.
Okay.
Okay. Where's Hannah?
Well, I don't know who it's
Here.
Kevin, you won't make this.
Does anyone know what those pills are?
Doxycycline, antibiotic.
100 milligrams?
Sometimes they'll sprinkle it.
So those windows have
This is
real
gonna be
locks
interesting
on
this
them.
time. He puts it in all of his extraction
You
sites.
still gotta
Oh,
get.
yeah.
But he just
Again,
told me
with-
he's gonna be putting it in the
Just wanna
sure
let you know.
rather than each individual one.
So you have
it.
So,
No, I'm almost- you're not being great.
to see if they actually.
Can you oversee
Anesthetic is a big thing.
Those tetracycline capsules?
that? Yes,
Okay. I use those a lot too.
I have ever since he told me about it.
Yeah.
Not now. If you
And it
did
is
it like
pretty
the moment they
amazing.
came out, you could.
You could-
But yeah, once you.
And this is.
It's tetracycline capsules.
Look at it when I go take a picture of it.
So Amanda, I'm gonna have you stand kind of over there.
Do you need to be by the door again?
No,
for
I'm
your
fine.
wife?
It seems to be working right now.
Go.
It's kind of like figuring out whether my back can stand it
Oh, yeah.
or my phone goes off.
Get over here, Hannah, where you're.
Are you, oh, you want me to assist? Okay.
Yeah, we're doing it just like we do every day at work. So this is who assists for which procedures. Okay. Just want to go no, rest your head in there. I'm trying to see where you're gonna be. I think gotta move this a little bit. I think there's a little delay.
Yeah, you said about 10 seconds, right?
okay.
Hope your camera didn't pick that up.
No. It's okay.
Come on, focus.
I think I have a lot of teeth.
Probably have to zoom out a little bit. Yeah, it's not focusing. It's not saying. So it's okay. Waiting for it. Looks like that's gonna be. Move the camera to.
So we have a YouTube feed on this as well.
You mind if I move the mask for you? I don't want it to get
Oh, that's fine.
dirty and you won't be able to wear it afterwards.
Okay, great. Want to zoom back?
So you may want to see both YouTube feed and this Zoom feed because the Zoom will not be showing the surgery and the YouTube feed will.
And then
Rob,
that's also a private room for just our people that are watching, right?
yes. So you have a link for the YouTube feed or
Yeah, they should have it already.
they should have it? Okay, that's fine. No issue. Thank you so much.
Okay. And you know where my extra battery is? They're not, so just leave it. I'll get this. Okay, I'm just gonna touch you for a minute here. How you doing there? Oh, this spot you felt it? Okay, that's okay, so I'm checking. How about here? A little bit there. I don't really think anything about that. I think it's just the headset that you had. Okay, so I'll give you a little more in the front there.
We are off camera.
Why?
Why? Because the palette is off camera.
So what I hear you saying is you need me to change the direction of it. So that,
I could never work for you. I'd have to be too technical.
and check the bottom. Finger down in there. Yeah, try not to scare everybody. Oh, you're scaring me.
I wasn't expecting that.
Well, in the infected areas, you know, you're going to be as numb as we can get you, but it doesn't mean you won't feel anything. Yeah, you're still alive, you know?
Yeah.
All right. I'll give you some more down the molar here too. Okay, well, you're not going to give you the anesthetic, so I feel like that's pretty good. All right. Yeah, I think it's probably better. Okay, is Robert out there?
I'll go get it.
Yeah. So I think what we have to do, just so my head doesn't block that, is to move the camera down here a little bit. All right. So that one's gonna be pretty good, Jim. Yes, sir. So
I want you to move
if I
the
lean
camera
forward, I can
back.
box the camera. So I need you to move the camera down here and shoot it this way. So loosen this one and this one. I'll get out of your way. But that's where he's gonna sit, so that should help. So, which way?
From more this way, so that his head doesn't block it if he's over here.
No.
Like this. Does that look good?
I think that'll help.
Um,
Yeah.
I think it'll help, yeah. He just wants to make sure when his head is like right here, like he's not blocking.
Yeah.
Oh, here? Yeah, this is a little light. I don't, this is not the leaves I normally use. This is my old leaves. A little wire.
Just repositioning the camera right now.
Do they work pretty good? These lights? But the one and the other ones, I have the work. I have the work. So I have the work. Sure.
That's, I forget.
Yeah.
Am I okay?
I think
That's
so.
not
heavy on
You think?
It's heavy.
It felt like it's a little.
It's heavier.
Oh,
It's heavier, but.
Or go up towards his nose a little bit.
Go upwards.
Yeah.
That's
Yeah,
good.
right. Yeah, you don't want yeah.
Yeah, right up here. There you go. Yeah, that'll work.
Open. You're gonna see.
It's heavy.
I think that's good.
Yeah.
That one's a little bit behind, but
Yeah, I use
again,
that bend
it's
because.
10 seconds.
Yeah, that's probably better.
Yeah, because, you know, then it's not.
Rock the safety day.
They said that this would be a yes.
That was good.
But he's got. That looks pretty light.
Get him?
I did the first one. He said to let you do the other ones.
What?
He said to let you do the other ones.
Oh, I just wanted to pull them out and see what's in there. That's
I'll
all.
see here.
Nope. Leave it in there. Because I don't want you to tilt it. Let's straight up. Because I got nothing with that second one. There you go. Pull that up. So as long as you can pull them all straight up and out, you're good to go. Okay, double checking again. Good. You got screen time? Did you run this?
Yeah. Yep, I did.
Getting the PRF ready.
Okay. Turn away for me.
I'm just chatting here a little bit on the outside.
So basically, I'm gonna go in here, and I'm really playing with the handpiece. Turn your left. Thank you. Turn your left. Thank you. Good job. Okay. Are you feel like you need some more anesthetic on the bottom? Because I've given you about 3 down there. Is that a yes? Would you like some more? Okay. So, were you feeling comfortable on the top? Are you comfortable on the top shelf? Okay. All right. Now open really wide this time. Open really wide this time.
Yeah.
Not feeling that at all? No, that's why I checked your head. Okay, well, we'll work on the top while that's happening there. Okay, turn away. Can you keep the volume down just so you can hear the camera what I'm saying? All right. Yep. And remember, you're gonna scare if you keep making all the noises. So anything you can do to help me is great. Turn away from me. Too bad we didn't know you were a little afraid, or we would have gotten you some of that medication so you could relax today. So I apologize for that. So if you look, I'm trying to get basically plus mobility on each one.
I apologize.
That's good.
I guess
Yes, for me.
he keeps moving back.
Yeah, he does.
Let the patient see that.
Yeah.
You know, it's funny, I've noticed that you guys probably do this too, like,
Let me get.
you get done with a case, you want to lay it back, do they want to see, hey, you want to see your restoration? And then they go,
Better right here.
Yeah, but he keeps moving on. I kind of want Robert to go in there and stay in there.
Kind of do right hand on right side of the arch. And left hand on left side of the arch. Turn away from me a little bit.
Yeah, it's just something a little bit.
I'm afraid if I touch it, I'll screw it up.
Well, what is, it's what the patient does. They lift their head back and then they're out of focus.
Yeah.
It's typical.
It's very typical.
You almost have to tell the patient, bring your head down a little bit. Notice he's using a rotating motion with his, I do that a lot.
There's a lot of stuff he does that he's explained, but then I just did it, and I didn't even know why I did it. It's just over the years.
You get used to it, yeah.
Just, but then one day I looked back in my old surgery book, and I looked at the root surfaces, and you know, things like that. I'm like, oh, he has a reason for doing it. I just did it because it worked.
Mm-hmm.
I never realized why I was doing it.
Yeah.
I'm just gonna move my patient instead. What do you need to move? Up or
It
down?
looks like he needs to come down.
That's it right there.
I think that.
The canine, the last one.
See it work, Jim.
I've got the way.
Canine and first molars would probably be the last ones they took out.
Better, one more
Probably be
time.
the one who-
Come down just a little bit more.
Move down the chair.
It's good.
There you go. Good.
Good.
Thank you.
It's just a cut. So
It's a mouth pack,
yeah, so
a throat pack, basically, only it's
foam.
just foam instead of, yeah.
Instead of gauze.
I like it better than gauze.
You like it better?
I do.
I've not used it.
Gauze seems to pack up after a while once it gets wet, and then it never does. It always stays kind of.
Yeah.
Man, he's like an old surgeon.
Now this one, you're not getting left side blown up there. So I can feel I don't want to have any pressure to get in the out. You're doing a good job.
Yep. Yeah.
Turn away from him.
I think they both buffalo weights came off.
Yep.
They might be fused.
You get your shoulder to your house, big fella? My cousin was over
6 inches.
He was like,
Middle
I
aisle.
was at the Sonic and it was like 78 degrees at 9 o'clock and he showed me that he was in altitude. He showed me. Oh, dude, this is my foot class. We left yesterday. It was 80 degrees when we left.
Texas?
Yeah. We really haven't gotten it down into the 70s yet. And you know, we got some nice weather. Yeah.
You feeling more numb on the bottom?
I get down with the curette.
Yes. Okay. How you doing with that? Can't feel that at all? Okay, I can't guarantee I'm gonna do any more now when I start doing this. In fact, see the kind of stuff. I might go as quick as I can, okay? Good job. Good job. You can do it. There's the extra.
Good job.
Is that Ornitz?
Is that what?
Ornitz powder, I believe.
No, I believe that's his antibiotic powder.
Oh, antibiotic. Okay, fine. Put it on the denture, I see. Okay.
Up a little bit after I get this in. Hey, back together. All right. You guys want to see the fit of the denture in the partial?
Yeah, it looks good.
We can see it. We can see it.
Let's step out of the way. You guys head on in. Go ahead. You can head on in and take a peek.
Let's see it.
And will you suture that up at all or just leave it?
No, denture does it. Yep.
So that's 300 milligrams doxycycline.
No, I think that's like a 250 or 200 in a tab.
Okay, and you use 3 tabs? Or just 1 tab? Okay, I saw 3 tabs sitting out.
This is in case I needed it. Two still sitting there.
Okay.
Yep.
Josh, was that one of
And
the
that's held
dentures?
in
Is that one of those
for 2
dentures?
days. So the antibiotics will soak and filter into the holes for 2 days.
Is that a lab-made custom denture, or is that
That's a lab-made immediate denture,
immediate
and
denture?
that's a lab-made partial.
The patient doesn't take the denture out for 2 days,
Right.
48 hours.
Right, because you're gonna have clotting, no suturing, because the sutures, will also be a barrier to healing. And then the antibiotics will sit and filter into the hole. So at this point, he's gonna have virtually no pain.
That's just a reduced chance of infection.
No, it's actually proven to make the bone grow faster.
Okay.
Yeah, so it'll heal and it'll improve as well.
I'm gonna walk through here.
That night, you can get the sucker back in.
Right?
Look, I
Yeah,
sent it
well,
to our old
swelling is
surgeon.
maximum in 2 days.
Yeah.
Well, if I use this thing, they were surgeon, they take too much bone and then they just fall
Take
out.
off front back.
So the idea is no flap, because your flap gives you the blood supply. If you raise a flap, you have delayed healing and you're gonna lose bone. If you don't raise a flap, you don't lose bone.
Don't touch
So that will heal just like
We
one
either
tooth.
do that or we
Okay,
open.
so no flap, that's the big thing. Do not flap.
And hold it behind the tooth so it doesn't choke them. So nothing falls.
Your bone gets its blood supply from the periosteum, not the other way around.
Interesting. Okay, so like this is it. You open it all the way. Yep.
So Rick, you can offer anybody that's virtual if they want to ask questions.
Well, what are you gonna do with PRF?
The PRF, we're gonna take that back out after bleeding stops in 10 minutes, and we're gonna put in the PRF. There is likely sinus communications on the upper left molars if you go with the X-ray. So I'm gonna pack those sites just to make sure that if there's any perforations or lateral fistulas, you're gonna be able to.
And that's where you use the PRFs mostly?
Yeah, anything, you can pack just the site, the PRF alone. If you look at the PRF kits, there's a little circular tube on the end. So you can put the PRF in there and you push it down. It's supposed to create a molar shape and then you pack it in the molar.
Mm-hmm.
But yeah.
Mm-hmm. Okay.
So cool.
Oh, okay.
So again, we're going to put the PRF in the molar. And then we're looking for
Dr. Lon, we have work to do.
well, I think there's likely some sinus communication here. So we're gonna take the PRF that you made, and we're gonna pack the molars. So these 4 sites, so that should be 4 pieces. We have 6. We can put the other 2 anywhere else you think we need. All right. All right.
You suture those in place.
Just, the denture's gonna hold it in. Yeah, remember this tissue adheres very quickly. So like in the plastic surgery world, we always want to take out our sutures in 3 days. If you don't, then you get a lot more scarring. sutures, remember, are a barrier to healing, just like a membrane. So you want to take them out, let the body do its own thing. The blood clot is forming right now, so all that antibiotic is stuck in the blood clot. Yep. So I was kind of watching this on, make sure I take it out.
For a couple of days, you'll swell, you won't be able to get them back in.
It should look like the time where you go, you know, when you hear the suction and it's already. It should look back.
But you're handsome.
I have a little out of talking.
Yes.
Yeah, so that, you might have some S's for a while.
What?
Like lift a little bit for a while. That's totally normal, you know. Like, don't worry about it. But you'll be used to it. Okay. Let's go put some here. Where's the QR?
Go ahead and put that in with something. It's hanging there. I got a bill.
No, I just don't want to be in your way. Yes, I've been his assistant for about a year and a half. Nice to meet you.
I've been here quite a few times. I think maybe the fourth time I've been here. Maybe the third. I can't remember for sure.
Yeah, this is my first class.
Oh, really?
Yeah, the last one he did here was the fall before I started. So
I was here. Yeah. I think Bruce was here for that three.
With the dentistry, that's actually. The other side is perfect. This one I see him like, try to see him every 3 months or so. Last time I was like, sometimes he just like, lower him. That's good about that. So I keep going, hey, you like, release it all. Huh? Oh, that's okay. I'm just looking for where else I was putting it. Maybe right in here.
maybe want you to do a lower molar too. Lower left. Let me take some. What's the left?
Oh, okay. That's probably why it's coming off.
Probably.
That's probably what your life. That's gone out of favor.
Yeah, that's probably using for that.
Yeah. That's what I use. They use the blue sky bio version.
Oh, yeah.
The Biomax, I think.
What's it called?
Biomax.
Okay.
Yeah. About $100, maybe 110 now.
That's about the same as the.
Yeah. Yeah, I love Tater Denture.
So how many do you replace?
4 on top, 2 on bottom. I mean, I'll offer 4 on bottom, but I'll do 2 on bottom, but I won't do just 2 on top. Yeah, they can do 4 on bottom.
So yeah, I started doing denture,
Like on the bottom, when this is one of those people with like no bone, like the
Give me
ACL,
mattress,
and then
yeah,
it's got
you're
like,
fabulous. I don't have a man.
you know, it's just a little tiny vertical block, and there's like
And nothing for you? I'll give you a good one.
getting to this one, you know, it's a nightmare when you try to go through the
Hey, kiss the straw. Close your lips.
you know,
There you go. And open. Okay, kiss the straw. Good job. And open.
Thank you, Bruce.
All right, ready, clean you up.
And then they have a high failure rate for moving. Apparently, they're really good for cakes. I do have one guy in MMA. It's like a cemented on.
Okay.
And that's what I think is really, you know, authorized to do that to all on four.
Right.
Say your name again. I never listened the first time.
Hannah,
Hannah.
with an H, yep.
Stay biting.
Terrible things.
I kind of am too.
I've got one right now that I just did where I've got, so it's a full upper palate denture, including a partial.
Do you want me to try to sneak it in?
Two single piece.
I don't know if you have it in that angle.
Get on the bottom. Yeah, one piece.
Okay,
So we're
bite
gonna
down.
connect
Stay close.
the board. Now, down to the crown. So we put 6 minis on the top. That's 2 from large red motor.
With those balls on them?
Oh, yeah, with little balls on that. And then, okay, so basically we've got 8 on the top.
Yeah.
And I'm like, I even put in a few extras of resistance training, and I just think, like, when things are gonna happen, I got 3 months. It's very good training.
So let me ask, when, with the teeth removed, did you remove the teeth or when they
Alright,
You look so pretty.
I think she did it wrong.
Yeah, they fit really well.
Yeah, they do. Right down, sit back down, keep pressure on
This
it.
was a learning case.
And they sure do.
Yeah,
look great.
it looks really good. It's very natural.
Beautiful smile.
Are you married? Are you married now?
Yeah.
Oh, no? All right, better watch out. Lie down, stay back down. Yeah, keep pressure on that for us.
And the veins kept coming
Looks
out.
really
The
good.
bully of the bone wasn't very good, so Dr. Brown came down. And he was like, okay, let's get her on vitamin D. We have to get some opposing, because what's happening, she's taking the partial out. Tipping, we're in a lower partial. I was pulling your minis out. So what we did is we replaced the minis. We banked 5 large implants, and then we put 1 mini out. We did primary closure on everything. So we get to the power. Yeah, right at the stable spine. So in other words, we were sitting on that, and all the minis were, I mean, they wouldn't be having pressure on them, right? Because everything was sitting on that. Then that one came out like 6 weeks, and then we saw the minis started to get
Has
exposed.
anybody told has Val
Then I
that they're
sat
done?
the bench on the minis.
It what?
Right?
I'll go tell her that they're finished.
And then I was gonna get
I believe so.
How are you? You gotta approximate the tissue a little bit, don't you?
No, because remember, I didn't make it flat.
Right.
So if I didn't make it flat, I didn't, oh, it just shows that I left as much bone as possible in the proximal.
Okay.
So I relieved the junction. I took out the PDL, which is what's attaching the Sharpie fibers to the bone,
Right.
so that it'll actually move.
But you also removed the papillae, the sharp points between the teeth, the actual papillae bone.
I removed the bone underneath the pillow, but I left the pillow attached so that I don't have to do any suturing.
Okay, very good.
How do you preserve your bone on your labial canines?
Rotate, rotate, because your canines are always an oval. So if you rotate in a circle, they'll just unscrew like a corkscrew.
So you're not removing any bone on the.
I never touch the buckle.
I don't touch the buckle either.
Yeah, don't touch the buckle.
Yeah, well, I guess you're going a little deeper just because of the anatomy.
Just past halfway down.
What do you think of the new osteotome type surgical removal of teeth? I don't know. They call it.
If they come out with a faster way than that, I'll switch.
Okay.
You know.
Okay.
I just, you know, it's one.
one elevator, and you know, like I can take them out with elevators and just keep luxating them until they all come out. But it's faster for me to pick them up with the forceps once they're loose, you know. And then a lot of people keep trying to luxate. You know, I'm gonna get these, and really, the roots are spread or they're bulbous, and they're gonna break them anyway.
Yeah.
So just break them, and then you've already got your tooth sections, and you can just flick out the roots. It's so much faster to do it that way. So I keep the forceps around really just to break roots so that they section for me. Otherwise, I get a section of the whole tooth, and then a bird don't last as long if I get a section of the crown too, you know?
I'll hack the crown off.
Yeah, I don't hack the crown
Break
off.
it,
I just break it off. Yeah, it's out of the
Was that
way.
prior to luxating it then, or?
Well, they usually come out all attached. If I remove enough bone, most of them will just come right out. But if the roots are fully spread or the roots are bulbous or curved, then they're gonna break anyway. So I just break off whatever is gonna come out, and then I'll just go back in and flick out the pieces if I can. Yeah, that just takes a couple seconds. But the idea is that if you section the crown off the top, then that root is still fully engaged in the bone. Whereas if you luxated it first, it's loose in the bone once you break the crown off, and then you just flick it out.
I should have had my dad on this, he would love to see that.
Well, it's being recorded.
Okay.
Yeah. Only recorded.
See a dentist or he just likes
Yeah,
drill
he's
stuff?
Dennis. I keep wanting him to retire, but he doesn't. So what he's done now is he works at a.
How you doing? Yeah. Was it fun?
Josh, huh? Was it fun? Oh, what?
Yeah, it gets actually.
Those meetings that we put in on Sunday, those are cognac? Which one? The meetings that we put in on Sunday?
No, they're going my way.
Yeah, they were white, the ones
On
we put
this?
in on the lower.
No,
No,
No, they were 15.
they were 15.
Yep.
How the hell did I try that?
Probably, and then.
But
But you really wasn't.
No, yeah, it was.
I think they're,
Just like a normal person would do.
I think $100 maybe.
He wants that.
I could look it up, but yeah, they're not bad. I'll get one to show you guys.
Yeah, no, there's a plenty of it.
Yeah, they're like 750.
Yeah, I know. Sure, it's for my blood. Yeah, me too.
What are you paying for a zirconia crown in your area?
Oh, 109.
How about you?
70.
Really? Wow.
Well, that's not in my area. I mean, I mail it to
Sure.
China. I mean, I mail it to California. then
I'm
I mail
paying-
it to Taiwan.
I'm paying $139 and I have the lab in my office.
I paid 109, but the lab's like 15 minutes away. They get it to me within 5 days.
I can walk over there and just, it's the convenience of it is worth it to me.
Yeah, absolutely.
Yeah.
Oh, I would do that for that convenience.
Oh, yeah, well, he does a lot of things at no cost, so it makes up for it.
But we'll,
Oh, okay, yeah.
You can go show them.
That one piece data that we put in on one of my patients.
Okay.
That was something.
Here's the,
I don't do any. Because it was around.
yeah, it's just a one piece. It released it. Yeah, I like it. But it was interesting that 2 oral surgeons were on both. And then we just put it right in.
I'm not sure if you're familiar with chromatobio, but this is the tooth grinder. So
Yeah.
if we do that, we can grind up all the teeth and put them back in as bone graft. So there's just a little attachment on the top. Amanda loves doing this. It's her favorite.
Amanda. So,
Basically, you put the teeth in, push the button, it's like a coffee grinder, grinds them up. You gotta denature them, and then you pack them in bone graft. They dissolve very slowly, like a bovine. Yeah, like I've gone into 2 years.
how do you denature them?
There's a solution they include
Yeah.
with the machine.
Just
And the
some
little
kind of-
pieces that go on the top are $60.
the manufacturer says that the healing is faster than allograft. Have you, I wait the same amount of time.
There's faster boning growth, but there's slower turnover than traditional allograft. Yeah, so basically, because you're gonna get some of the actual growth factors from the teeth themselves from the pulp.
So that's what they're saying.
Mhm.
So turnover is not really a factor. It's
So I was
bone
telling
growth.
them that this worked out so well.
You don't care for
Well, you know, Denton's going to resorb a little slower.
Yeah.
Yeah.
But the bones is growing.
Yeah. Yeah. Straight up.
No, but what I'm saying is that the manufacturers say that the healing is faster.
Mm-hmm.
So that's really the thing you're looking for, right? That's the primary thing, not the turnover, but
Yeah.
the bone growth. That's most important. Like, when are you going to place an implant in there? Well, if bone growth is faster, you can place that implant in sooner.
That's right.
But how do you make sure you're going lingual nerve and not hit the nerve? Well, remember, it's just like a mini, you're not drilling all the way down. And then you're starting lingual, because we did a surgical guide, so we knew we started lingual, we knew it should go lingual. And then because the mandible is hollow, the nerve will move.
Okay, so it's specifically because it was a hollow man.
And with a conventional implant, you traditionally would have to drill full depth, and then with this, you don't, because it's hollow. You do have. So that's why these were specifically done just for this case. It was unique. The drilling was unique, everything about it was unique.
The
But
minis
your
were-
own
the minis
surgeon
were-
said you couldn't
you couldn't
do it.
do it,
Yeah, he said you couldn't do it. We did 4.
Two on each side. But you could, a mini in principle can work that same way, right?
Yeah.
That's how you put minis
Yep.
there, because you go lingual and then you hit.
The reason for the conventional versus the mini is that there's no bone. So, to grab anywhere below. And so the idea was she had cortical bone all the way around like a chicken bone. And so we had a lot of surface area at the top where the cortical threads were. So we were getting primary stability there. Because this is an implant patient. There was like 12 implant failures on the side before because nobody really took the time to look at the CT and the vitamin D. Well, it's just a matter of, I had a periodontist in Connecticut that hires me to come out, and she's like, I just did my residency, man, and just do a full arch case. So some guys like you that met me at a course one time worked out there, and they wanted to restore it, so they wanted her to replace it, and she didn't know how to do it, so they asked her to ask me. So I went out and I looked at the CT. It was like yours or worse. And I said, this patient has high cholesterol, low vitamin D, and their vitamin D was 6, which is really bad. And the cholesterol was like 2. And so we had delayed the trip out there for about 4 months.
So how did you tell that she had that low vitamin D?
You can look at the bone and just see it. You can just see it.
Yeah.
And so, so I just told her, so she went and checked it, and she's like, well, I guess I'm gonna be checking all my patients from now on about that. And then it was funny because her husband was an endodontist, and he decided he was gonna get an implant and change his mind. And so we had to remove, it was a full arch immediate, and we had to remove the molars and hollow mandible because it takes like years for that to grow back. So I used maxi plants, the big 9x11 implants and molars, and then he wanted to use up his expired implant that he bought, so we just randomly had to use whatever he had for everything else. And so we did, and the case got restored like a year ago, and it was perfect. So she was really happy.
Or the same way.
Yeah, but every case is different. When you get to full arch or you get to tricky stuff, it's tough. So my lab has a distributorship fee, so you can get them, I think, for like $85, something like that. So it's I like those. They're not for every case, but if I had a place where I put a mini and it's a grinder, I'd use that instead.
What is this? How was the diameter?
It's a Tatum implant. It's a 1-piece.
What is it? 4-1?
Oh, it's a 4.0.
Yeah, there's 4.0, 5.0, 3.5. Yeah.
Oh, pretty cool.
Yeah.
With a fixed above it.
It's Conant Bridge. Yep.
What do you place it with?
Just the normal driver. Just a
On the driver, like same as you would for
I got, here you go.
no,
I have 18 surgical kits.
yeah, that's got its own kit.
Okay, you just gotta get it for it.
You doing pretty good?
Yeah.
Did they tell you not to take it out for the first 2 days?
Yep.
Okay. Did they schedule time to come back and see?
Yeah, that's.
Like
You put 2 in on each side where the oral surgeon.
It's really cool looking.
Yeah, that.
Yeah, it's looks
Yeah.
like a tape.
They told me good. I mean, they put it like 40 or 50. That's good.
Well, it's on YouTube.
Yeah, they were
It's
really
on
good.
YouTube. So the only other doctors
They were just gonna connect them.
What do you use?
You can have your own channel. I looked the other day, I have subscribers to a YouTube channel I didn't even know I had.
Apparently, I posted some stuff that was okay to have public, and I had a whole bunch of people sign up to watch it. I'm like, why do you want to watch my private stuff? But so be it. Yeah. No, there's there's somewhere between 5,000 and 10,000 people that kind of follow me online. So yeah. Well, I think we did great. Bike feels good too, doesn't it? Yeah. I thought so. It looked good when I put it in. So, all right, let me get one of the assistants. How do you feel pain? I know pain wise, you seem like you're struggling a bit when we started. But how's your number the first case?
Yeah, so like I was saying, he did the case, he did the upper.
Do you have any allergies?
They start coming out.
Oh, right.
It's like,
All right, I think what I'll do is I'll get you some Tylenol
not
codeine
super,
and then
like
rotate
bottom, you
that
put it
with
on
the
hard.
because the ibuprofen's better for pain. Okay. T3. And then the ibuprofen 800. Now I want him to rotate too. So
Like I said, if we get the right
in Illinois when I was
Switch speed over to here. Not see. So make sure.
I have my laptop too if you want it. What are you asking for?
Yeah, I knew.
Sorry,
Go ahead.
I didn't mean.
There, it's good. Work.
Well, I only use it once a day.
I touched
And I said,
something
oh,
and messed it up.
Okay, so I want you to use it 3 times a
Oh, no,
day.
you did it. That's not a touch.
Okay,
screen,
and
is
I
it?
want you to
Yeah,
switch
yeah,
for 2
touch.
minutes. You probably want to switch for
I
a
messed it
minute,
up.
right? We'll switch for 2 after you.
So that one does it.
She might only do 2 times a day.
Yeah.
And I told her 2 minutes because she'd probably only do a minute. You know, just, it's like telling her mother to show up 30 minutes early.
Right.
Because she knows she's always late. So, but anyways, but I absolutely told my mother, you cannot have Candida because you're on Oracare.
Right.
And she said, oh, but I only use it once a day. And I said, well, use it 3 times a day for 2 minutes.
All right. So conclusion.
And she went right away.
Well, the conclusion of the microchem study was that it had 0 toxicity on human lung fibroblasts. Okay, and it killed at 99.99% or a 4 log kill. Okay. Summary of the pre-rinse: it must be an oxidative a product. I think oxidation works better. If it's mixed, it must be mixed. It must not be inactivated substantially by the cell defenses. In other words, like hydrogen peroxide is often inactivated by catalase in the tissues. And, glutathione, things of that nature. It must be safe to use. Should not kill, it should kill quickly, not just bacteria, but also the yeast and fungi. It must not impede the wound healing. In other words, because we're removing methyl mercaptan, hydrogen sulfide, and other disulfides, this is helping healing. It must remove the toxins. Okay, and then you can purchase these items here. One is dentalsleepbalance.com. If you want to purchase these products. In Dental Sleep Balance, you will see. And by the way, it'll be on a different website soon because I'm making a new website. Because this is a sleep apnea training system. But if you go to Pandemic Safe Office,
Well, these are sites for buying what?
all these are infection control products. So
I got you.
you'll see down here. First, this is the Clean Air EXP system. Okay, and then down below,
I thought it was Sleep RD down there.
no, it's changed. And then look, sleep balance, dentalsleepbalance.com. And then you'll see the fogging sprayer here. See the fogger? I'll show you the fogger. We make this fogger ourselves, so there isn't any company that does this. We make this ourselves. There's the fogger. It hooks into your airline system, and it comes like with the HOCl container at the top. Okay. All right. And then go back to pandemic safe products.
You got about 3 more minutes, and we're gonna see our patient.
All right. I'll be done in a second here.
We're gonna add a couple mini implants to.
There's your dolphin
existing
pods.
overdenture.
Order dolphin pods there. Your ultra safe filtration system is there. Circle ring, we didn't talk about that, but we can talk about that later. Reverse osmosis water. Your whole office purification system, clean air, and your Oracare. Now you can't do your Oracare here, but it'll take you to the Oracare website. You can't buy it from me, you have to buy it from the company. OracareProducts.com. And then there's your BioSure, this is your ozone line.
All the other equipment that you showed is on
All everything but Oracare. Everything but Oracare.
And it's about a week and a half delivery time from the time you order.
Products, right?
We have run out of inventory at times. We've run out of inventory and
Yeah, don't wait till you're gone.
yeah. Don't wait, because sometimes we've had delays. I mean, just
What are you thinking?
what?
Don't run out of products.
Oh, well, you know.
They have big,
Never do that.
we're talking, they have big,
No, they
they have
don't.
big bottles
No,
for
they
you.
don't. They're not doing the big upgrade.
Yeah.
So
Oh, they got them back.
The big ones?
Yeah, the big ones are back.
So the big ones you would use for.
I'm gonna turn
up for a second. So you
guys asked about a hollow mandible. This patient.
Yeah.
Okay, so we're done with our presentation. Thank you. We're going back upstairs to see a patient.
In office, I just keep some cups, 3 pumps of each. Give the patient do that. So that's my in office. They can buy the big take home bottle.
Or if they have a perio condition.
Yes,
they're
and
gonna
they're
use
gonna be on
forever.